Choosing Wisely Canada is a national campaign aimed at reducing unnecessary tests and treatments in healthcare. In this video, we present one of the top 5 dermatology recommendations for physicians and patients, which are set by the Canadian Dermatology Association and Choosing Wisely Canada. Don't routinely use topical antibiotics on a surgical wound. Let's start the discussion off with a case. Carl, a 65-year-old male with a history of multiple squamous cell carcinoma, presents today to the ER with a 2-day history of rash over his surgical site. 1 week ago, he had surgery on his right forearm to remove his squamous cell carcinoma. He has been following the post-op instruction of changing his bandage and applying over-the-counter Polysporin daily. On examination, you can see the incision site is healing well, but there is an overlying, sharply demarcated, bright pink and edematous plaque with some vesicles. The skin is slightly warmer, but there is no significant tenderness or purulent discharge upon palpation. What other questions do you want to ask Carl? Does he have a wound infection? Should you prescribe him with oral antibiotics? Most in-office surgical procedures, such as skin biopsies and skin cancer excisions, are classified as non-contaminated or clean procedures due to its sterile technique and the lack of body cavity involvement. These wounds have a low risk for infection of under 5%. Topical antibiotics are frequently used following office procedures with the goal of promoting healing or preventing infection. In North America, common topical antibiotics include neomycin, bacitracin, mupirocin, polymyxin B, fusidic acid, and gentamicin. Studies have shown that there is no difference in the rate of healing or infection following dermatology office procedures when comparing the use of bland ointment, such as white petroleum, against topical antibiotics. Meta-analyses and systemic reviews have shown marginal to no reduction in surgical site infection with topical antibiotics. Furthermore, exposure to topical antibiotics can lead to undesired consequences and medical harm. These include allergic contact dermatitis and risk of developing antibiotic resistance like methicillin-resistant Staphylococcus aureus. Only the wounds that show symptoms of infection should receive appropriate antibiotic treatment. Moisture and occlusion provide the ideal setting for wound healing. For example, white petroleum and a simple Band-Aid dressing. These are recommended as standard post-op care. Topical antibiotics may be considered in circumstances that confer a higher risk of infection, such as those with deeper surgeries, high-risk sites such as the groin and concave, or in immunosuppressed patients. We will focus our discussion on allergic contact dermatitis as it is an important reason of why we should avoid routine use of topical antibiotics on a surgical wound. ACD is a T-cell mediated, delayed type hypersensitivity response to exogenous agents. Clinically, the most common presentation is acute eczema. Compared to irritant contact dermatitis, ACD requires prior sensitization or exposure and can occur 24 to 48 hours after exposure to the offending agents, which in our discussion is the topical antibiotics. A risk factor for ACD include an impaired skin barrier and prolonged use of the offending agents. Polysporin is a very common and popular over-the-counter topical antibiotic. The ingredients include bacitracin, polymyxin B, gramicidin, lidocaine, and vitamin E. All ingredients have the potential to sensitize patients to trigger the development of allergic contact dermatitis. There are different formulations of polysporin. One important difference to note is that polysporin complete ointment contains lidocaine, whereas polysporin triple antibiotic ointment does not. Neomycin is one of the most common allergens in topical antibiotics, but is more widely used in the US. Fusidic acid and mupirocin, which require a prescription, have low sensitization potential and has a less chance of causing ACD. When you see sharply demarcated erythematous plaques over a well-healed surgical scar, be sure to ask if patients are applying any topical antibiotics, which may cause the ACD. ACD is diagnosed clinically. As we will see later, it can be mistaken for cellulitis, which results in hospital admission, unnecessary or even harmful diagnostic workups, or even systemic antimicrobial therapy, which can lead to a series of adverse reactions. Therefore, it is important to pay attention to the details of the rash to help you reach the right diagnosis. A detailed history should be done to review the patient's activities, which include occupation and hobbies, and the use of personal and hygienic products. There are 3 important factors to help you make the correct diagnosis clinically. First, the symptoms. The dominant and differentiating symptom that patients will complain of in ACD is intense pruritus. It can also be associated with burning, stinging, or pain. Second is the primary morphology. ACD can be classified into being acute, subacute, or chronic. Acute ACD presents as erythematous, indurated, scaly plaques, sometimes with vesicles, and bullae. The plaques can also be oozing or crusted. In skin of color, erythema can be difficult to appreciate, or it may appear violaceous or even gray. In chronic ACD, you will see lichenification, scaling, and fissuring. Subacute has a mixture of both acute and chronic features. Third is distribution. ACD is typically localized to the skin areas that come in contact with the allergen. However, allergens can often be transferred from the primary site of contact to distant skin areas. For example, the hands or even the face when applying the topical antibiotics. Sharp demarcation or geometric pattern also points towards outside job from the allergen. Sometimes ACD can cause id reaction, also known as autoeczematization, which is when the dermatitis occurs at skin locations distant from the initial site of ACD a few days to weeks after its onset. Patch testing to panels of ingredients may be required to confirm the diagnosis and identify the specific culprit allergen. This testing is different from skin prick testing through an allergist, which tests for immediate hypersensitivity. Re-exposure to the culprit allergen will also trigger the same rash. Afterwards, patient education to help them understand the nature of their allergen is essential, and when appropriate, a list of safe products that are free of the identified allergens can be provided to patients. For ACD, topical corticosteroids are the first-line treatment. Depending on the body location, medium to high-potency topical corticosteroids can be used BID until clear. Topical calcineurin inhibitors, tacrolimus or pimecrolimus, can also be considered. Aluminum acetate compresses and calamine lotion can be used to reduce itch and swelling concurrently. Oral corticosteroids may be indicated if there is a large area of involvement, if there are severe symptoms, or if fast relief is desired. For our patient Carl, in the absence of significant tenderness or purulent discharge, the papulovesicular rash with sharp demarcation over the well-healed incision site should make you think of underlying inflammatory processes rather than an infection. When asked, Carl also endorsed a significant itch and prior use of Polysporin complete ointment for his prior surgeries. The rash is most likely caused by ACD due to bacitracin, polymyxin B, gramicidin, lidocaine, or the vitamin E, which is found in the polysporin. For management, he should avoid polysporin. Clobetasol propionate 0.05% cream or ointment can be used BID topically for 2 weeks. If possible, he should be referred for patch testing to identify the specific allergen. From this video, we hope you understand the CWC's recommendation of don't routinely use topical antibiotics on a surgical wound. The take-home messages of this video are: wounds from most in-office surgical procedures have a low risk for infection. Due to the risk of antibiotic resistance and ACD, topical antibiotics should not be routinely used to prevent post-surgical wound infections for clean in-office surgical procedures. After a detailed history, specifically consider the presence of pruritus, primary morphology, and the distribution of the rash to help make the diagnosis of ACD. Rather than topical antibiotics, white petroleum or moist occlusive dressings should be used as a prophylactic measure to prevent post-surgical wound infections for clean in-office surgical procedures.